Hello, welcome to Stanford Center for Asian Health Research and Education Community Health Talk Series. My name is Nina Lee. I'm the Program Manager for Stanford Care. Our co-founder, Dr. Brian Ling, will be joining us during the Q&A to moderate the session. I'm proud to bring you another series of talk on Asian health, which co-sponsored and co-hosted by our very own Stanford Health Library. Great thanks to Vincent VC Wu Foundation for sponsoring the talk as well. I'm really pleased to welcome Dr. Meryl Sperling, who will be speaking on early screening and diagnosis of gestational diabetes mellitus in Asian subpopulations. Dr. Meryl Sperling is a fellow in maternal-fetal medicine at Stanford University. She was previously part of the Japanese exchange and teaching program where she taught English in rural Japan and subsequently received a Master of Arts in Secondary Education at Columbia University Teachers College. She attended Georgetown University School of Medicine and completed her residency at the University of Hawaii. Her research interests include gestational diabetes mellitus and maternal health disparities in Asian American and Pacific Islander populations. Please join me and welcome Dr. Meryl Sperling.
So thank you very much for that introduction. My name is Meryl Sperling. I'm one of the third-year maternal-fetal medicine fellows, and my research interest has really been through fellowship on gestational diabetes. So I'm excited to speak to you today about gestational diabetes in Asian subpopulations and also talk about some of the work that I've done. I have nothing to disclose. And in terms of our objectives today, we're going to be discussing the rationale for early gestational diabetes screening and its risks and benefits, and then also define overweight in Asians as it is different in Asians than it is in other populations, and then analyze the risk of gestational diabetes in different Asian subpopulations. Okay. So what is gestational diabetes? And so it's carbohydrate intolerance that develops in pregnancy. So as the placenta grows, it releases hormones such as estrogen, cortisol, and another hormone called human placental lactogen. And human placental lactogen, it decreases maternal insulin sensitivity and leads to an increase in maternal blood glucose. And normally the pancreas is able to make additional insulin to overcome insulin resistance. But when production is not enough to overcome the effect of placental hormones, then the result is gestational diabetes. And gestational diabetes has many parallels to type 2 diabetes. It's abnormally increased insulin resistance along with inadequate pancreatic beta cell adaptation. And you'll hear me using the term GDM, which is just a shortened phrase for gestational diabetes. And so we traditionally diagnose gestational diabetes between 24 and 28 weeks of gestation. And so as if a pregnant patient comes to us, as long as they have no previous history of type 1 or type 2 diabetes, then everyone is universally screened for gestational diabetes at this gestational age. And the prevalence in the United States, it's quoted as anywhere between 6 to 25%. And that really depends on the population that's being studied, as well as the modality that is used to screen and diagnose this disease. And we'll go into that in more detail a little bit later. And then there's really two classifications of gestational diabetes. We say that people are either A1 GDMs, which to us means that they're diet controlled. So they'll get a nutrition consult and they'll have someone go over their diet with them, and hopefully they'll be able to control their glucose levels just by kind of controlling the amount of carbohydrates they eat and eating like a very nice diet. Whereas A2 GDM are patients that are unable to be controlled with diet and then need medications in order to meet their targets. And the first line medication for us is always insulin. But if someone is unable to take insulin or they're not a good candidate for insulin, then the second line medication would be metformin, and then a third line would be glyburide. And those are the three mainstays kind of medication management in gestational diabetes. And, gestational diabetes itself, it's a very intensive in regards to its management. It requires a lot of buy-in from patients. And so once a patient has gestational diabetes, they are going to be asked to check their finger sticks 4 times per day. So we ask them to check a fasting value and then a value after every meal, so breakfast, lunch, and dinner. And they can either do a 1 hour or 2 hour postprandial. Usually at Stanford, we tell patients to do a 1 hour postprandial. It's just kind of easier to remember, I think, to actually check your sugar an hour later than 2 hours later. But either is fine. And the 1 hour postprandial target is less than or equal to 140. And then the 2 hour target is less than or equal to 120. And we know that hyperglycemia in pregnancy can lead to neonatal and also maternal complications. And so things that we're worried about in terms of the neonate with hyperglycemia are things like macrosomia, which in a lot of studies for gestational diabetes is considered to be a weight that is 4,000 grams or more. And then also neonatal hypoglycemia. So this can result because if a mother is having high sugars, that kind of hyperglycemic environment will be around the neonate. And in response to that, the baby will start making a lot of insulin. So if you have a mom that's not super well controlled with her gestational diabetes, when the baby is born, because you no longer have mom's maternal kind of glucose environment around, you can have neonatal hypoglycemia. And in addition, you can have neonatal hyperbilirubinemia, and then birth trauma, because a lot of times these babies get big, and if they get big, they can have difficulties such as shoulder dystocia. Their fat distribution is different, and so we worry about things like brachial plexus injuries and other types of birth trauma. In terms of maternal complications, things that we always think about are preeclampsia. So that's one of the hypertensive disorders of pregnancy. There was one study that looked at if you had a fasting blood glucose of less than 115, there was 10% of patients ended up getting preeclampsia versus almost 20% if your fasting blood glucose is greater than 115. So very related. And then also cesarean birth. So patients who were diet controlled had about a 17% chance of getting delivered by cesarean birth versus 25% who are on medications. And this is versus 9.5% of controls. And then one thing that we always want to tell patients about is that their future risk of type 2 diabetes, which can be up to 70% within 22 to 28 years after pregnancy. And so, pregnancy itself is a great window into the future health of a patient. And it's a great time to be able to teach people about nutrition, and then also discuss their risk for screening after pregnancy, so that if they end up having type 2 diabetes, they have earlier recognition and treatment as well. And so what about in Asians? And so this is, I think, an area that is a very interesting research gap that I think will be, that is something I'm very interested in doing more work on. And so this was a study that was based out of Ontario, and it's a population-based healthcare database study, and it looked at 35,000 patients between 2002 and 2011 who had gestational diabetes. And in Ontario, the most prevalent Asian populations are Chinese and South Asians, and they compared just patients that had gestational diabetes to those to the rest of the general population who had gestational diabetes. And they looked at many of the things that we are concerned about. And what was interesting, though, is that the Chinese patients pretty much had a lower incidence of these adverse neonatal and maternal outcomes than South Indians and also the general population. They even had even lower risk of cesarean birth. South Indians and Chinese had lower incidence of shoulder dystocia. It was, and which kind of also makes, I think, intuitive sense, because a lot of the complications from having like a shoulder dystocia or a macrosomic baby, in terms of when you compare Asian babies to babies, mothers born to non-Hispanic whites, there is a 200 to 400 average, weight difference in between. So Asian babies tend to be a little bit smaller as well. And then how about in the United States? So this is looking at GDM outcomes among Asians in Hawaii. And this is a retrospective cohort study of patients referred to a gestational diabetes program from 1995 to 2005. It looked at over 2,100 patients. And it broke the categories down into Native Hawaiian and Pacific Islander, Japanese, Chinese, Filipino, Caucasian, and then combined. And, when they looked at things like preeclampsia, it did seem like there were a little bit more in the Native Hawaiian Pacific Islander group, but the other groups were pretty similar. Shoulder dystocia was actually very similar between all groups. And then in terms of the type of delivery, so Native Hawaiian and Pacific Islanders had almost 20% of babies that were greater than or equal to 4,000 grams. They also had higher rates of neonatal hypoglycemia and hyperbilirubinemia, which could indicate kind of not as good control of their gestational diabetes prior to delivery. And then interestingly too, when I look at the Chinese patients as well, they also have lower rates of cesarean delivery in this study at 20%, which is, like 5 to 10% lower than the rest of the subpopulations that are studied. And that's kind of a similar finding to the study out of Ontario, which I think is very interesting. And so why do we treat gestational diabetes? And really, we treat gestational diabetes because we know that it can improve outcomes. And so this is a study coming from the Maternal-Fetal Medicine network. And essentially, the MFMU network is multiple institutions across the United States who recruit patients for trials in order to have kind of strength in numbers to answer interesting clinical questions. And in this study, patients were in their 24th to 31st week of pregnancy, and they all had gestational diabetes, and they were randomized to expectant management versus treatment. And treatment included having, a dietary consultation, checking their finger sticks, and then, if needed, starting insulin. And what they found was that those who were in the treatment group had better outcomes. So they had a lower mean birth weight, they had lower neonatal fat mass, there was less frequency of large for gestational age infants, you had less birth weight greater than 4,000 grams, lower shoulder dystocia rates, lower cesarean birth, and then reduced rates of preeclampsia and gestational hypertension. So really giving merit that we should be actively treating this condition in order to improve outcomes. And then this was another landmark study called the Hyperglycemia and Adverse Pregnancy Outcomes Study, also known as the HOPO trial. And in this trial, patients were given a 2-hour oral glucose tolerance test, which is a fasting test. You're given a 75-gram glucose load. And with this study, they followed 25,000 patients, and they tried to see if there was a certain cut point where they could say that the risk of certain outcomes that they were looking at was increased. And they couldn't necessarily find a cut point, but what they found was that there was a continuous relationship between maternal glucose levels on each of the 3 values of the 2-hour oral glucose tolerance test for things like cesarean birth, birth weight greater than the 90th percentile, neonatal hypoglycemia, and then fetal hyperinsulinemia. And so, this is the first trial that really looked at birth outcomes based on the diagnostic modality that was used to diagnose gestational diabetes. And we'll get into more about kind of methods for diagnosing gestational diabetes, but because of this study, essentially the rest of the world changed the way that they diagnose GDM, and they all, most parts of the world use the 2-hour oral glucose tolerance test. The United States is one of the only countries that still uses a different way primarily to diagnose gestational diabetes. And so how do we diagnose gestational diabetes? And, I think when most people think of diabetes, they think of a hemoglobin A1C, but I think we need to remember that with gestational diabetes, it's diabetes in pregnancy. So we wouldn't expect patients to necessarily have an elevated hemoglobin A1C. If they did, and it was consistent with type 2 diabetes, then we would just diagnose them with type 2 diabetes at that time and then treat them as such. And so, for gestational diabetes, patients will have a normal hemoglobin A1C. But in addition, we're going to talk a little bit about hemoglobin A1C and how it's also not necessarily the best measure in pregnancy. So when sugar enters your bloodstream, it attaches to hemoglobin, which is obviously a protein in your red blood cell. And then everybody has some sugar attached to their hemoglobin, but people with higher blood sugar levels will have more. And so this A1C test measures the percentage of your red blood cells that have sugar-coated hemoglobin on it. But it's affected by conditions that alter the red blood cell lifespans. So for example, iron deficiency anemia can prolong red cell survival time and increase hemoglobin A1C levels. And pregnancy itself is a state of altered RBC kinetics with increased erythropoiesis and also with hemodilution. And so this was a recent study that just came out, and they basically took patients and had them complete an oral glucose tolerance test, and then also do a hemoglobin A1C at the same time. And they did this at 3 time points. They did it at the end of the first trimester. They did it again at the end of the second to the beginning of the third trimester. And then the last time was in the postpartum period. And what they found was if you got a hemoglobin A1C with the glucose tolerance test in the first trimester, it correlated pretty well with the hemoglobin A1C estimated average glucose. But when you get to the late second trimester, early third trimester, you see that the hemoglobin A1C kind of underestimated the mean glucose. So the mean glucose was 111.2, but the hemoglobin A1C estimated average was 99.6. And then it went, and this is the time period when most patients will be getting their gestational diabetes screen. And then in the postpartum, it goes back again to kind of normal, what you would expect, which I think makes sense. And so how then do we actually diagnose gestational diabetes? And there's 2 main methods. We call it the 1-step and the 2-step method. And the 2-step method is the method that is most commonly used in the United States. This is the 1-hour oral glucose tolerance test, where you take a 50-gram glucose load, and then an hour later, we check your glucose. And you don't have to be fasting for this test. You can be eating whatever you want. Every institution will have their own kind of cutoff that's between 130 and 140. At Stanford here, we use 140 as our cutoff. And so if you have a glucose value that's 140 or greater, then we would then reflex you to then doing a 3-hour oral glucose tolerance test, which is a fasting test with a 100-gram glucose load. And if 2 of the 4 values are elevated, then that's diagnostic of gestational diabetes. And based on a survey study done in 2003, more than 95% of OBGYNs in the US use this 2-step method. We actually recently just reevaluated this to see if it was still the same. And in our study, it was still over 90% of OBGYNs still use this 2-step method in 2021. And so the other method that is used is the 1-step method. And this is the 2-hour oral glucose tolerance test, like the one that I talked about for that HOPO trial, where you use the 75-gram glucose challenge, and it's fasting. And the thing to note about this method is that it will diagnose approximately double the number of patients as having gestational diabetes than if you use the 2-step method. And so it's a lot of controversy because gestational diabetes is very expensive to treat. It requires a lot of healthcare resources. You need to have clinical diabetes educators. You're doing nutrition consultations. You're having patients have a glucometer and check their blood sugar 4 times a day. They're having more frequent OB visits. So it is a very comprehensive disease. And so, what does ACOG recommend, and ACOG is our governing body. It's the American College of Obstetricians and Gynecologists. So they still recommend that we do the two-step method. And that's because in 2013, the Eunice Kennedy Shriver National Institute of Child Health and Human Development felt that there was lack of evidence that the one-step method leads to improved maternal or neonatal outcomes with a significant increase in healthcare costs. And then in 2015, there was a Cochrane review that found that there was no specific screening method that has been shown to be optimal. And so most places around the country are still using this two-step method because it's recommended by ACOG. And then interestingly, in 2021, there was a US randomized controlled trial that was done. And this compared the two-step versus the one-step. It was a Kaiser study. They randomized patients to either undergo the two-step method versus the one-step method. And what they found was, as expected, those who did the one-step method had about double the incidence of gestational diabetes diagnosis. So 16.5% versus 8.5% in the two-step method. And then, but when they looked at the outcomes, there was no difference in outcomes like large for gestational age, the perinatal composite outcome that included stillbirth, neonatal death, shoulder dystocia, bone fracture, and nerve palsy. And then gestational hypertension or preeclampsia, and also the primary cesarean section. So what is early screening? And so, I just kind of went over just the normal route where someone comes in, they're an uncomplicated pregnancy, then we would screen them all universally between 24 and 28 weeks. However, if someone who comes into our office and we consider them to be extremely high risk for gestational diabetes, or we think there's a chance that they could have undiagnosed type 2 diabetes, then we would perform early screening on these patients. And early screening would typically be performed at the first prenatal visit. And really it allows for the opportunity to start treatment prior to the standard screening time of 24 to 28 weeks. That would potentially decrease the fetal exposure to hyperglycemia, because as we've been talking about before, we know that treatment can improve outcomes. And so it's extrapolated that early screening could assist in improving these perinatal outcomes. So ACOG, which is, obstetrician's governing body, says that early screening for those who are overweight or obese with additional risk factors should be performed. And this is a very controversial topic right now. The US Preventative Task Force, however, says that there's insufficient evidence to recommend early screening, and there's potential harms of screening for gestational diabetes that include psychological harms and intensive medical interventions, including induction of labor, cesarean delivery, and there's possible adverse effects of treatment that include neonatal or maternal hypoglycemia and maternal stress. And then the National Institute of Diabetes and Digestive Kidney Diseases, well, they say that early screening is a research gap that requires more level 1 evidence. And so really you have these three bodies. ACOG says yes to early screening. The US Preventative Task Force says no, don't do it. And then the National Institute of Diabetes and Digestive Kidney Diseases says we need more evidence and we don't have a stance. And so this is a narrative review that looked at the current evidence of early screening in gestational diabetes, and it was done by Nakajima. And it included 37 cohort studies and 8 randomized controlled trials. And data from observational studies he found showed that the potential benefit of screening and treatment in early pregnancy showed conflicting results. And then smaller RCTs couldn't show benefits, but there are several large RCTs ongoing. And so I know this is a very busy slide, but these are going over the kind of the 8 RCTs that he had mentioned in his paper. And so, the top one with Osmundsman, they found that early treatment did not significantly reduce the risk of gestational diabetes, except in non-obese women, except, the sample size was like 83 patients, so pretty small. And then Simmons did a study in Australia that found that there were more NICU admissions in the early GDM group with a tendency for more SGA, but less, which means small for gestational age infants, but less large for gestational age infants. And, but it only had 79 patients. However, this study was like a pilot and feasibility study. And so currently He is undergoing the study looking at 4,000 patients. The results are currently not in, and there's no manuscript yet, but we are waiting with bated breath. And then there's a Rotor study that found that treatment in early pregnancy did not improve maternal or neonatal outcomes. And then the most famous is the Harper study that found that early gestational diabetes screening in obese women did not reduce the composite perinatal outcomes such as macrosomia, C-section, and shoulder dystocia. And so this is looking more at that Harper study because this Harper study had quite a few patients. It had 922 patients in it. And so this compared early gestational diabetes screening to routine screening in obese patients. And the primary outcome it looked at was a composite of macrosomia, primary cesarean delivery, hypertensive disorders of pregnancy, shoulder dystocia, neonatal hyperbilirubinemia, and then neonatal hypoglycemia. And what they found was that for the primary composite outcome, there was no significant difference between the two groups. And actually, there was a higher number of patients in the primary composite outcome in the early screening group than in the routine screening group, but this did not meet significance. And then in terms of the secondary outcomes that they looked at, the only difference that they really saw was insulin medication, so that if those who had early screening were more likely to be put on insulin than those in the routine screening group. And so I think that the jury is still out regarding early screening. I think theoretically it makes sense that you can decrease the amount of hyperglycemia that's being exposed to the fetus, but a lot of these trials that are coming out right now are showing that there's no difference in outcomes right now. And so it'll be interesting to see kind of how ACOG will respond to this information. And so who is eligible for early screening? And so this is from ACOG. So patients who are overweight or obese and that have one or more of the following risk factors. And these risk factors include physical inactivity, a first-degree relative with diabetes, if you come from a high-risk race or ethnicity, and that's described as being African American, Latino, Native American, Asian American, or Pacific Islander, if you've given birth to an infant before that's greater than 4,000 grams, if you have a previous history of gestational diabetes, if you have chronic hypertension, dyslipidemia, history of PCOS, hemoglobin A1C greater than or equal to 5.7, a pre-pregnancy BMI of greater than 40 or acanthosis nigricans, or a history of cardiovascular disease. So when you think of kind of patients in general, many patients are going to fall into this early screening algorithm. There's also no guidance as to what physical inactivity really means. And so it's a very subjective call. And I would say that many patients that we see in our clinic would end up meeting criteria for early screening. And so how do we define overweight? And I think we're all very familiar with BMI classifications. And so the World Health Organization says overweight is greater than or equal to 25. In terms of early screening for GDM, ACOG says consider testing in all women who are overweight or obese, which means a BMI of 25 or greater, but 23 or greater in Asians. And so why is it different in Asians than in other populations? And so this was from a WHO consult series, and it looked at, it was talking about how patients with a BMI of greater than or equal to 25 who are Asian are noted to have higher percentage of body fat when compared with whites, and then also have increasing rates of diabetes and cardiovascular disease. And in the same expert consultation, they put cut points to be added for points of public health action. And so if you look at the bottom, it shows the WHO classification for underweight at 18.5, overweight at 25, class 1, class 2, and class 3 obesity at 30, 35, and 40. However, in terms of when they look at Asian populations, this consultation series was saying that we should consider to be overweight at 23 for Asians, 27.5 for class 1 obesity, 32.5 for class 2 obesity, and 37.5 for class 3 obesity. And so in terms of kind of also why it's defined differently in Asians, they also looked at kind of the body fat percentage in Asians. And And so they compared them to white patients with a BMI of 25 and a BMI of 30, and then tried to then say what a BMI in an Asian person would be to have that same body fat composition. And for a lot of the BMIs, it's lower than the comparison. So in China here, it'd be 24 versus the 25 in a white person versus 27 in rural Thailand versus 25 in a white patient. And so as you can see, even within the different subpopulations themselves, there appears to be heterogeneity as well. And then, it was also found that all-cause mortality risk increases for Asians at lower BMIs. So this is a study that came out of Taiwan. It was a national health interview survey that looked at middle-aged patients in Taiwan. There were over 36,000 civil servants and school teachers who were aged 40 and older who underwent a medical exam during 1989 and 1992. And what they found was that all-cause mortality risk increased for Asians at lower BMIs. And so this is a comparison of relative risks for mortality from all causes according to BMI levels between Asians and US Caucasians. And they looked at, the comparison was from a study that was, a health and nutrition examination study that was performed by the United States. And what they found was that Asians showed risks that were equivalent to Caucasians at lower BMI, but every unit of BMI increase at 25 or above, it was associated with a 9% increase in relative mortality risk from all causes. And so really, as you can see here, just the relative risks for those in Taiwan were higher than when compared to the US cohort. And so, what does it necessarily mean to be Asian? And so the Census Bureau defines a person of Asian race as having origins in any of the original peoples of the Far East, Southeast Asia, or the Indian subcontinent. So obviously this is a kind of massive geographic region with many cultural backgrounds. And so, it encompasses a wide range of geographic, ethnic, and cultural backgrounds. And really few studies have examined gestational diabetes in the context of these diverse subpopulations. And I think we're lucky in California that we have the largest Asian population in the United States. And so we can really do some meaningful studies to look at Asian patients and then also kind of gestational diabetes and complications. And so this was a study done by Henderson, and it was looking at patients through the Kaiser Permanente Northern California system. It looked at over 123,000 patients who delivered between 1995 and 2006 who had gestational diabetes. And what they found was that, as BMI increased, there also was an increase in gestational diabetes diagnosis. So you have the BMI categories are over here. This is impaired glucose tolerance. So that really meant that just they didn't meet full-blown gestational diabetes diagnosis, but they had probably one value that was elevated on their 3-hour oral glucose tolerance test. But, if you look at even the numbers here, you have much higher numbers in Asians at these BMIs for pretty much every BMI listed than for non-Hispanic whites and African Americans and Hispanics. And they only disaggregated Filipina and Asians, and they did seem fairly similar in this study. And then this looked at the fraction of gestational diabetes that was attributable to overweight and obesity by race and ethnicity in California. And so they calculated population attributable fractions for gestational diabetes. In this study, they analyzed over 1 million records of patients who were age 20 or older, who had a live birth in California between 2007 and 2009. And they used logistic regression to estimate the magnitude of the association between pre-pregnancy, body mass index, and GDM, and then calculated the percentages of GDM attributable to overweight and obesity. And in this study, they said that the adjusted percentages of gestational diabetes deliveries attributable to overweight and obesity were 17.8% among Asian and Pacific Islanders. And actually, if you compare these to the other groups that were studied, this is very low. So 17.8 for non-Hispanic, Asian, and Pacific Islander. But if you compare it to non-Hispanic American Indian, it's 57.8. Hispanic is 44.2. So these are all in the 40s and 50s, but the Asians and Pacific Islanders are at 17.8. And then it was further broken down for this population attributable factor by Asian subtype. And I think what is extremely interesting is when you look at, Vietnamese patients, they have the third highest prevalence of gestational diabetes, but their population attributable factor is extremely low when you look at overweight, obese, and then total overweight and obese. And this is true even for some of the other Asian subpopulations as well. The reason why these numbers, the reasons why these numbers at the bottom for total overweight and obese seem higher than kind of the other study is because they also put in overweight 1 and overweight 2 with a 23 to 24.9 for overweight 1 for Asians as well. And then, we've looked at acculturation as well. And its association with gestational diabetes. And in previous studies, it's been noted, so acculturation is the social process by which racial and ethnic minority people adopt the behaviors, practices, attitudes, and values of the host country. And so you look at things like nativity, the language spoken at home, and the length of residence in the United States. And in previous studies, it's been noted that higher acculturation has been associated with an increased risk of diabetes among Hispanic people. A lot of the discussion has been that higher acculturation is often associated with, a worsening diet quality, and then an increased stressors of being potentially separated from your family or facing discrimination. And so I think that actually this investigator was thinking that you would see a similar trend with Asians, but in this study, acculturation score, so they had patients also do an acculturation score, and it was 0 to 5, and they found that a higher acculturation score was negatively associated with having gestational diabetes. And so this was a population-based cross-sectional study among 5,500 patients who delivered in Los Angeles. And they found that Asian patients had 2.44 times the odds of having gestational diabetes, but that acculturation was protective. So the multivariate model 1, it adjusted for maternal age, marital status, and the annual household income. And then when they added acculturation, this is here. And so the acculturation score showed this potentially protective effect. So I think that this is something that definitely warrants more study into as well. The researchers did say that they did not have access to the kind of food that patients were eating and the nutrition that they had, and so this could also would help kind of help them figure out kind of why this was. And so I'm today going to talk to you kind of about a study that I was involved in, and I looked at pre-pregnancy body mass index and gestational diabetes across Asian subpopulations in California. And we really wanted to analyze the association between BMI and gestational diabetes among Asian subgroups along a BMI continuum, because we felt that like a lot of the studies have looked at BMI and GDM in like very discrete categories. And we hypothesized that there'd be a wide variability in GDM diagnosis at different BMI ranges between groups. And so for our study, we used California's Office of Statewide Health Planning and Development, which links birth and fetal death certificate and maternal and infant hospitalization discharge records for births in the state between 2007 and 2017. And we included people who self-reported as one of 13 Asian subpopulations that's collected on that form. And then pre-pregnancy BMI was calculated from height and weight reported in vital records. We included patients who like I said, self-reported as one of the 13 Asian subgroups. This included Cambodian, Chinese, Filipino, Guamanian, Hmong, Indian, Japanese, Korean, Laotian. There's a Hawaiian and a Pacific Islander category, but we combined them because of the smaller number of Hawaiian patients, Samoan, Thai, and Vietnamese. And then patients who had more than one delivery during the time period were included. And then we identified DDM as it was reported in hospital linked discharge data or vital records data. And so we excluded patients who had a diagnosis of pre-gestational diabetes, if they have multi-fetal gestation, so like twins or higher, if they identified as more than one race, if their hospitalization was not linked to the birth certificate data, if they kind of had implausible birth dating, so if their gestational age when they delivered was less than 20 weeks or greater than 44 weeks, if patients did not indicate when they initiated prenatal care, because we really wanted to adjust for that and to see if that could potentially explain something. And then if they had height or weight that was outside of expected normal ranges for people. And then we calculated the distribution of maternal characteristics across Asian subgroups. We looked at pre-pregnancy BMI, nativity, parity, so how many babies they've had before, maternal age greater than or equal to 35, because this is considered to be advanced maternal age, educational attainment, the payer status for delivery hospitalization, and then the trimester prenatal care was initiated. And then we calculated the incidence of gestational diabetes in each Asian subgroup overall, and then separately among those with a BMI of less than 23 and also greater than or equal to 23, because that's the cut point for overweight in Asians. And then we used multivariable logistic regression to evaluate the nonlinear association between BMI and GDM separately in each Asian subgroup. And we adjusted for age at delivery, education, parity, payment method, nativity, and the trimester prenatal care was initiated. And so here we have at the top the 13 Asian subgroups. And I know this is a lot of information, but I think it is interesting to be able to see that there is, stark differences between the groups. Like if you look at age greater than or equal to 35, you have only 8% of the Hmong population who is greater than or equal to 35 at delivery, whereas 50% of Japanese patients, I guess me included, would be in here, delivered at age 35 or greater. And then when you look at things like nativity, you only have 8% of Indian patients who were born in the United States. You can contrast that to 68% of Samoan patients, and then BMI category as well. So you look at Samoan patients and they have over 50% of the patients who delivered as considered to be obese, whereas, come down here to Vietnamese and it's a very small number. Sorry. And then, when we look at other things like education and payer type and trimester, they started care. So even for those who are college graduates, if we look at things like Indian and Chinese, very high rates of having a college degree, as a in contrast to Samoan, so our Samoan population here. And then, when we look at trimester, we started care. You have more patients in the Pacific Islander group who started care in the third trimester, also in the Samoan group as well, versus like 1% of those in Japanese and Indian subgroups. And so these are our results that we found. And so, we had 584,032 patients that were included in this study. And then the overall prevalence of gestational diabetes was 14.3%, but it really ranged between 8.4% in Koreans to 17.1% in our Indian population. And then when we looked at it at less than 23 versus greater than 23, so this table breaks down the 13 subgroups by BMI, and it found that, and then followed by the total prevalence in each subgroup by all BMI values. Among those with the BMI of less than 23, if you look at Vietnamese, Indian, Chinese, Thai, and Filipino subgroups, 10 to 13% of these patients were diagnosed with gestational diabetes. So these are patients who are in a normal weight category. And then GDM was least common in Korean, Japanese, Samoan, and Cambodian subgroups, with only 4 to 6% of these patients being diagnosed with gestational diabetes at a BMI of less than 23. And then interestingly, while Samoan patients had the highest rate of obesity, so greater than 50%, they had the second lowest prevalence of gestational diabetes at 8.7%, and the lowest rate of gestational diabetes at a BMI of greater than or equal to 23. Whereas you look at Vietnamese patients, they had the lowest rate of obesity at 2.4%, but the highest rate of gestational diabetes at 15.5%, and they had the highest rate of gestational diabetes at a BMI of less than 23. So it's very varied. And then, so this figure then depicts the predicted probabilities of gestational diabetes risk by BMI in each of the 13 Asian subpopulations. And the red vertical line denotes a BMI of 23. And we adjusted for age, education, parity, insurance type, trimester the patient entered prenatal care, and whether the patient was US or internationally born. And then we found that there was significant variability in the association between pre-pregnancy BMI and GDM diagnosis, although an increasing BMI was associated with a higher risk of gestational diabetes in each subpopulation. And that the groups vary both in the prevalence of gestational diabetes at each BMI and also in the slope of the association between BMI and gestational diabetes. But we do think that there is a delineation between two separate groups at a BMI of 23. So I think that this can be considered kind of like a high risk group, and this is like a lower risk group. This higher risk group would be Filipino, Indian, Vietnamese, Chinese, and Thai. And they have a higher risk of GDM, both at lower BMIs and in total prevalence. And if you look at even a BMI of 30, this subgroup, more than 20% of these patients are going to end up being diagnosed with gestational diabetes. And that's a pretty significant number. And so this is just breaking it down by region. And so Southeast Asian here, Vietnamese, Filipina, and Thai are kind of these higher groups here. And then when we look at East Asians and Indians, Chinese and Indian are kind of these upper ones. This Korean is kind of up like this at the very end because we just didn't have a lot of numbers, I think, at these higher BMI ranges. And then interestingly, when we look at the Pacific Islanders, the Hawaiians, the Samoans, the Guamanians, the slope of their lines appears to be a lot less steep than the other populations that were studied. And so, the strength of the study, it's a large and diverse study population. It adds granularity in being able to examine gestational diabetes in 13 Asian subpopulations. We were also able to analyze across a large range of BMI values, and we were able to demonstrate the risk along the BMI continuum for each subpopulation. Limitations, however, are that we were unable to ascertain how gestational diabetes was diagnosed. We don't know if they were diagnosed by the one-step method or the two-step method. That's not going to be in birth records. We were unable to know which week in pregnancy the patient was diagnosed with gestational diabetes. There's no information regarding if medications were used or the glycemic control that they had. So we don't know if they're GDMA1 or GDMA2. We rely on ICD-9 coding, and there's always a potential for misclassification of BMI. In terms of future directions, so I think the next place that we're going with this data set is we really want to look at perinatal outcomes in Asians with GDM. And so, a lot of the studies have compared GDM patients like in Chinese versus GDM patients who are South Indian versus GDM patients who are just everybody else. I would like to study GDM patients who are from who are East Asian, and then also compare them to patients who don't have GDM to then see kind of the correlation, to see if there's a difference really in a lot of the outcomes that we are concerned about, like large babies, cesarean birth, and those types of things as well. And so this is something that we are currently working on and is underway. And so in conclusion, gestational diabetes and its association with BMI, it varies among Asian subgroups, and subgroups with the lowest incidence of obesity really trended towards the higher incidences of gestational diabetes. And we really felt that Vietnamese, Chinese, Filipina, Indian, and Thai subgroups created this distinct kind of high risk group that providers should potentially be aware of in terms of risk stratification. And then I just want to say thank you so much for the Center for Asian Health Research and Education for inviting me to speak today. It was such an honor to be asked. I also just want to thank our Maternal-Fetal Medicine division at Stanford for always supporting my research and also helping to fund some of my research. And then these are some of my co-investigators, Dr. Leonard, Dr. Blumenfeld, Dr. Carmichael, and Dr. Chue, who have also been on the study that we just spoke about. And with that, I would be happy to take any questions you may have. Thank you so much.
Thank you, Dr. Sperling. Latha Palnipan here. I'm honored to moderate the Q&A for your wonderful talk. We are so impressed by the work that you are doing for Asians in the US and around the world in terms of improving birth outcomes. So thank you. And thank you for acknowledging the Vincent V.C. Wu Memorial Foundation. So we have many questions. We won't have time to get to them all, so we will definitely have to invite you back. This is a great topic and focus of lots of interest and further research. I'm going to group the questions. First, I'll ask about the categorization of race ethnicity, and I have done research mostly using census data and mortality data. And I know there are limitations to how race ethnicity is coded in these national data sets. And there are some questions about Hawaiians being combined with Pacific Islanders. And I know there is a movement more appropriately to separate out Native Hawaiians. And I know you yourself have done work in Hawaii and are particularly alerted to that issue. And then also multiracial, how that was handled in your analysis. 1 out of 7 babies in California currently are multiracial. Mothers are also highly likely to be multiracial. I will say in the cardiovascular work that we have done, and I'll shout out to Dr. Iha Data, who is joining us from Hawaii and a collaborator there. We've seen that multiracial individuals have higher cardiovascular disease risk, and wondered if there were any signals with that for gestational diabetes. So Dr. Sperling.
Okay, thank you so much. It's a lot of questions in one. If I miss any of them, please we can circle back. In terms of multiracial, I think that is something that needs to have a lot more research done on. In terms of gestational diabetes data, there has been just like 1 or 2 studies that I've really seen that have looked at kind of birth outcomes in those who identify as more than one race. I will say, like in one of the studies that I did in Hawaii, the way that I think everyone, depending on how you do the study, kind of classifies or is able to classify race and ethnicity in different ways. In Hawaii, in one of the studies that we did, it's self-reported. So patients that identified as more than one race in one of the studies that we did, we ended up classifying them by what race they entered first, because that we felt like that was what they identified with more. In this data set that we used for this particular study, it's patient-reported data in terms of what they identify as in their race and ethnicity. And we actually excluded patients who identified as more than one race. However, if they, the only ones that we did not exclude were those who were Hawaiian. If they were Hawaiian and said they were something else, then we would classify them as Hawaiian in the study. And yes, I totally understand the concern regarding kind of trying to disaggregate Hawaiian population from other Pacific Islander populations. And I think that, you know, if I were to do this again, we just, at the beginning of this study, we didn't have we had smaller numbers because we were looking at an older set, and we were able to kind of expand the set to more to encompass more years, which gave us a greater population depth, which I think would have been useful for the study to be able to disaggregate that. And I think I'm missing one other question that you asked me about.
I think that was great, Dr. Sperling. Lots of food for thought there. I'm going to combine a couple of other questions on what are the possible reasons that Asians have a higher incidence of gestational diabetes and type 2 diabetes in general. And then does rice in Asian cultures, consumption of rice, affect the prevalence of gestational diabetes and type 2 diabetes?
Yeah, I think that the question about dietary intake is an interesting one, which could explain kind of that acculturation being protective in Asians for gestational diabetes. And unfortunately, they didn't have the, any nutritional data to really look at, but that was one of the things that they had kind of hypothesized in their article. For my thesis, we did a randomized control trial that looked at eating or not eating prior to the 1 hour glucose tolerance test, and then seeing it if affected results. One of the secondary analysis that we do plan on doing is actually looking at kind of the dietary content of those who actually ate before their glucola, and seeing if what they ate affected kind of the results that they had. But I don't think that it's fully understood why Asian patients are more likely to have gestational diabetes, although, we have more patients who are Asian as well, who are more likely to develop type 2 diabetes. And I think if anything, it's kind of, like we said in the beginning of the talk, it's kind of like a window into your future health, which is kind of why I think pregnancy is such a magnificent time to be able to get that kind of clarity, so that you know your risk and are able to kind of know that you need surveillance, and also have the tools to kind of live a healthier lifestyle.
Wonderful message, Dr. Sperling. So there's some questions on screening, which I'll group. And I will also do a public service announcement. There was a question on if you could self-screen for gestational diabetes. And I will say the answer is no. Please get prenatal care and get the gestational diabetes screening that Dr. Sperling recommended, either with the one-step method or the two-step method. And so there's some questions on risk. If gestational diabetes is diagnosed during first pregnancy, will it be present in all subsequent pregnancies? And then what is the chance a child will have diabetes in the future if a mother has gestational diabetes?
Okay, those are great questions. So if you have gestational diabetes in a previous pregnancy, it doesn't mean that all of your subsequent pregnancies are going to be affected, but it is very likely you have much higher risk because every subsequent pregnancy that you have, you're a little bit older, and even an older maternal age is associated with gestational diabetes as well. You obviously have shown in the past that you kind of have some type of insulin resistance going on. And so I would say that, there's no absolutes in obstetrics, but if you had like 3 pregnancies that had gestational diabetes, you got pregnant again, you would likely have it, but it's not 100%. I'm sorry, I forgot your other question.
The chance if a
Right.
child will have diabetes in the future, if the mother has gestational diabetes.
Yeah, and I think that they've done some longitudinal studies that have looked at this, and there is an association with babies, with kids having higher rates of obesity, and then also I'm not sure about gestational diabetes and like when they get older, but diabetes in a first degree relative is associated with a higher risk in a patient having gestational diabetes when they're pregnant.
Wonderful. Well, thank you so much, Dr. Sperling, again, for your wonderful talk and for answering all the questions with your expertise. We're at the top of the hour, so I will wrap up our session today. Thank you so much. We look forward to supporting your work through CARE and also having you back to hear about your future findings. I'd like to thank the Stanford Health Library for sponsoring our hour, and Nina Lee, who is our Director of Community Programs at the Center for Asian Health Research and Education. And thanks again to the Vincent V.C. Wu Foundation for sponsoring this talk.
Thank you so much for having me. I really appreciate it.